Hi everyone. Sorry for my late post this week. Like many of you, I was kind of dreading this assignment. And disclaimer, I have a puppy who doesn't quite understand what it means to be quiet yet, so you might hear some input from Sir Houndstooth through my recording, so I do apologize if that happens. So if you remember anything from what I said during orientation, I am going to be doing my D&P project on neonatal palliative care and bereavement. And from the concept map from last week, I've decided to kind of focus on the bereavement piece for this part of the presentation. So let's start with what is bereavement. And bereavement is defined as the period of grief and mourning after a death. And just like anything else, people have different bereavement styles, I guess you could say. They react to death in different ways and therefore can have a lot of different emotions that go into it. It is of note to say that it is different from palliative care, in which any baby or any person that is in the hospital can receive palliative care, and that is more like a pain management thing and comfort measures, and bereavement is what we would put into place if an infant is actually going to die. So the concept map that I did kind of on one branch was the resources for bereaved families. And a lot of these things are available in the NICU if you know how to ask for them and where to ask for them. But my project is really going to focus on getting all of those things in one place so that families have an easier time accessing those resources and making sure that we are giving them the best care that we can, in addition to having a pleasant death experience for their baby. So community support could include support groups within the NICU or in the community. That would also be kind of where social work comes into place if the family needs to stay somewhere close to the hospital, set up Ronald McDonald or in actually the hospital, those types of resources. And then we like to make keepsakes of the baby. So photos and footprints, locks of hair, measurements, anything like that, pacifiers, blood pressure cuffs, anything that we can provide the family that's going to be a reminder of their time with their baby. And then kind of along with that, bonding time, which is difficult to do in some situations, and we'll kind of cover that in the next slide, but we want to be able to give parents the time to bond with their baby as much as possible. And that can include bathing or hands-on care, changing diapers, holding if it's appropriate, if the baby is stable enough, etc. And then spiritual counseling, a chaplain in-house if they would like to have the baby baptized prior to the death, if they want to have family members around the bedside to have some type of prayer for the baby, anything like that, we also want to make sure that we can do for that family. And then lastly would be mortuary services. If the family wants to have an autopsy done, if the family wants the baby cremated, if they're going to be taking the baby with them to have them buried with a funeral home. So there's a lot of barriers that are within the NICU, and not necessarily just in the NICU, but since the NICU is such a unique place, it is very difficult to get these things all together. So the NICU itself is a very busy place. There are babies that are there for months at a time, so it's very difficult to focus all of our efforts onto one baby that is possibly dying. Along with that, the fragility of patients. So we can see death in the neonate for any number of reasons. They can be genetic, congenital anomalies, birth trauma such as asphyxia that would lead to brain death, anything like that. So the fragility of the patient would impede bonding, like I said previously, if parents want to hold or provide care and the baby is not well enough to do such. We try to find different ways that they can interact with their baby. Sorry. And then limited time. So some of the babies that we admit into the unit that are going to not be with us very long kind of puts a limitation on how long the parents have to make memories and how often or how much time they get to spend with their baby. And then lastly is kind of a provider barrier that we face, and that's that we're kind of stuck in a curative mindset. So instead of switching to kind of a palliation mindset, we're still thinking that we can cure the baby. So, you know, if we're still doing labs all the time, if we're still monitoring, doing assessments, and not leaving the baby to rest and to spend time with the family, then that's an additional barrier. So that is the portion of my concept map that I decided to focus on for this part of the presentation. Once again, I apologize for Sir. Here he is again, my puppy. He's almost a year old, and hopefully he'll gonna get a little bit more used to this, especially if I'm gonna have to be doing these types of voice recordings. And you might just hear him again in the next part of the assignment for this week. So that's all I have for you, and take care.